Okay, guys, this is chapter 32 on nutritional support and IV therapy. Please remember to go to Blackboard and watch any of the YouTube videos that I have assigned to help support this. Make sure you go to your Evolve account and watch the skills videos on chapter 32. All right, let's get started. Okay, so let's go through IV therapy and nutritional support. Doctors order nutritional support or any kind of IV therapy, and we're trying to meet the needs of their fluid and food intakes, okay? Some people can't eat because of illness, surgery, or injury. Some people are refusing to eat. Maybe they're eating and they're not getting all their nutrients met because they're not absorbing it or whatever. Or maybe they're an aspiration risk as far as chewing and swallowing problems. We don't want them to aspirate any food or fluids or vomit or into their lungs, so that might be a risk too. Poor nutrition results when a person cannot or will not eat. Okay, so maybe they can't swallow, chew, all that stuff. Maybe they've had some kind of injury or cancer or something to the esophagus or the stomach or the small intestines. Okay, they might have had trauma to their face, dementia, things like that, eating disorders, nervous system disorders where they no longer can swallow. Prolonged vomiting from some illness, surgery, AIDS, all that stuff. Okay, so those are interfering with them getting proper nutrition. Enteral nutrition is giving nutrition into the GI or gastrointestinal tract through a feeding tube. Gavage is the process of giving that tube feeding. Okay, we would do tube feedings to replace or to supplement normal eating. Different kinds are the NG tube or nasogastric tube. It's inserted through the nose into the stomach. Then you've got the NE, nasoenteral tube, and that is through the nose into the small bowel. Gastrostomy is a stomach tube. The doctor is going to surgically create an opening into the stomach and insert a tube. The JJ tube is a feeding tube inserted again through the physician, making a surgical opening into the JJ of the small intestine, and the PEG or PEG is also inserted with the physician, okay? NG tube, again, here it is. It goes through the nose and it goes right into the stomach. The NE tube or nasoenteral tube goes a little further into the small intestines, but still through the nose. There's the surgical opening that the physician has made, and he puts the tube into the stomach and it stays there. And then you've got the JJ tube, again, it's going down into the small intestines. Surgically created opening by the physician also. And then the PEG tube is inserted by the physician. All right, we got to make sure that the tape and everything is secured to the patient's nose for any of the NG or NE tubes. So we're going to give different kinds of formula depending on what the doctor orders. He's going to order what kind of formula, how much to give, and when to give. We want to make sure that the formula is given at room temperature because cold fluids can cause cramping. Most of these formulas will have carbohydrates, proteins, and fats along with minerals and vitamins. We can open a can of formula at room temperature for about 8 hours. Microbes will grow in that warm formula, so we have to be very careful of the storage and how long it's sat out. Scheduled feedings are intermittent feedings, and they're given at certain times. We'll want to make sure we try to give 4 feedings each day if that's ordered. The nurse will use a syringe or a feeding bag to do that. A continuous feeding are given over 24 hours, so it's continuously going all day long. We always want to make sure we know if, like there is an alarm, and if it goes off on that 24-hour feeding, we need to make sure the nurse hears about it, okay? Formula for a tube feeding is given. Let's see what the answer is. At room temperature. The person is at risk for diarrhea, constipation, delayed stomach emptying, and aspiration. So it could come back up and go into the lungs. So we've got to watch for that. So we want to look for signs and report to the nurse at once. Any nausea, discomfort during the feeding, vomiting, a distended belly, coughing, complaints of indigestion or heartburn, redness, swelling, drainage, odor, or pain wherever the site is. So if it is an opening that the doctor has created, we need to watch that for any kind of infection. Fever, signs of and symptoms of respiratory distress, difficulty breathing, that kind of stuff. Increased pulse rate, complaints of flatulence, which is gas, and then diarrhea. Again, aspiration is going to be a major risk from tube feedings. It can cause pneumonia and death. It can occur during insertion and also from the tube getting dislodged from where it should be, and that can be caused by coughing, sneezing, vomiting, suctioning, poor positioning, things like that. Or, the tape isn't, it's not only tape and pinned to the shirt, this has come loose or something that constantly is pulling, so it's pulled out of position, okay? To help prevent this from happening, the RN is going to check the tube placement before she ever feeds that patient, or if the patient is getting 24-hour feedings, that she checks it every 4 hours, okay? It's not your responsibility to check the placement of the tubing. We always want to position the person in Fowler's or semi-Fowler's position before feeding them, and we want to prevent them lying on their left side immediately or even during those feedings, okay? We want them to maintain that Fowler's position or that semi-Fowler's position for a while after feeding so that we don't have that aspiration happen, okay? Let's see here. So at PCT, you're preparing a patient to receive a feeding through the NG tube, and he is resting in his bed on his side. What should you do? Right, we're going to raise the head of the bed to the semi-upright position. Okay. Persons with feeding tubes usually are not allowed to eat or drink. They're going to suffer from things like dry mouth, dry lips, sore throats, things like that. So we want to give them comfort care every 2 hours, give them oral hygiene, put some lip balm on them, and offer mouth rinses, okay? Feeding tubes can irritate and cause pressure sores on their nose. So, and we want to make sure that we keep that area clean. We keep checking every 4 to 8 hours and make sure that that tape is secured. And again, we want to pin it, the rest of the tubing, make it like a little loop and put it on the shirt, because that way it won't keep tugging at their nose also, okay? We can assist the nurse with feedings. Some states and agencies teach and train their nursing assistants and PCTs to give tube feedings and remove the NG tube, but you would have to have that extra training. And you are not ever responsible for inserting the feeding tube or checking its placement. All right, when receiving continuous enteral feedings, at what degree elevation should the head of the bed be positioned? 45, okay? Parenteral nutrition is giving nutrition through a catheter inserted into the vein. It's usually called TPN. Nutrient solution is given directly into the bloodstream. Nutrients do not enter the GI tract. So these can include water, protein, carbohydrates, vitamins, and minerals. And it's going to be dripping through a catheter inserted into a larger vein. Usually we use this when the person cannot receive oral or enteral feedings, or if those oral or enteral feedings are not enough and it's not meeting the person's needs. Some common reasons for TPN include disease, injury, or surgery to the GI tract, severe trauma, infection, or burns. That person being MPO. Remember, MPO is nothing by mouth for more than 5 to 7 days. GI side effects from cancer treatments, prolonged coma, prolonged anorexia, which is a loss of appetite. Okay. Some risks include infection, fluid imbalances, and blood sugar imbalances. It's never perfect. It's not like real food, so we kind of get into trouble sometimes with their blood sugars. You want to report to that nurse any fevers, chills, or any kinds of signs of infection. any kinds of signs of infection of sugar imbalances, which are going to be some of these that I'm going to mention, okay? Chest pain, difficulty breathing or shortness of breath, cough, nausea, vomiting, diarrhea, thirst. Thirst is one. Rapid heart rate could be one. Weakness or fatigue, again, could be a sugar thing. Sweating, pale skin or paler, trembling, confusion can be also a sugar imbalance too, okay? When providing care, always check the placement of the feeding tube to prevent aspirating. What do you think? Nope, you do not check the feeding tube. Now, if you think it's out of place, you get the nurse, okay? Assisting with TPM, the nurse, again, is responsible for TPM. You can help observe the patient while she's doing the TPN. You can help that person with his basic needs and activities of daily living. So anything that you know, all the care that you're going to learn to give. Again, and providing that frequent oral hygiene, lubricating their lips, and mouth rinses, okay? A nurse asks you to give a tube feeding, and the procedure is not in your job description. What should you do? And you're going to refuse to perform the task politely, remember. Okay. IV therapy, so, is giving fluids through a needle or catheter inserted into a vein. The doctor will order the IV therapy, which will provide fluids when that person can't take things by mouth, or it's going to replace minerals and vitamins that are being lost, maybe because of maybe diarrhea or the illness itself. It also can provide sugar for energy and give drugs and blood through this IV, okay? RNs are responsible for IV therapy. Some states will allow LPNs to do some of it. I want you to go to your NHA site, and in Module 1, there is a video on catheter removal. I want you to watch that. And also on Blackboard, I have put a YouTube video on how to remove an IV catheter. I want you to make sure you watch that also. I've also put an outline of the step-by-step on how to remove it on Blackboard. Now, these are all in week 5, okay? So I want you to make sure you know that. Peripheral and central venous sites are also used. Peripheral IV sites, so peripheral, remember, is away from the center of the body, so we're talking places like the hands, the back of the hands, or the inner forearm, or that kind of place, okay? Central IV sites are closer to the heart, so we might use a subclavian vein or a jugular vein. Cephalic and basilic veins in the arm are also used. Catheters are inserted in these sites, and they are called peripherally inserted central catheters, or PICC lines, okay? Central venous sites are used for peritoneal nutrition, to give large amounts of fluids, for a longer-term IV therapy, and to give medications that normally would hurt if you gave them into these peripheral sites, okay? Some do irritate the area. Basic equipment, there's an IV bag, you've seen them. So it's a plastic bag with a solution in it. There's a catheter or a needle, that's what's inserted into the vein. You've got the tubing that connects the needle to the machine, okay, and to the needle. There could be a clamp that's used to help regulate the flow rate. Also, IV bags hang from IV poles or a ceiling hook, or there could be a mechanical machine being used. The doctor will order the flow rate, how much he wants to be infused, and what time period he wants it to be given in. The nurse will figure out the flow rate, which is the number of drops per minute or milliliters per hour. She will set the clamp for the flow rate, or on an electronic pump, she'll set the controls. An alarm could sound. If something's wrong, you're going to get the nurse. You're not going to adjust that, and you're going to tell her that you've heard the alarm go off, okay? Never change the position of the clamp or adjust any controls on an IV pump. So when you hear that go off, you need to go get a nurse. You can check the flow rate if the pump is not used. So in an old-fashioned one, you can count the drops per minute. So I want you to count for 1 minute the drops that go into that little chamber, and you can report that to the nurse. Now, if it's an old-fashioned one, it's going to say on the bag or somewhere right there how many drops per minute it should be going. If it's not dripping, you're going to report it. You're also going to report the rate if it's too fast or too slow. Okay. Um, what else can I tell you? All right, you help maintain that person's safety, hygiene, and activities. Um, in some states and agencies, you can change the dressing at the peripheral site. You would never be changing centrals. And you can also discontinue a peripheral IV, and we're going to learn how to do that. You're never responsible for starting or maintaining IV therapy, regulating the flow rate, changing IV bags, or giving blood or IV drugs. Okay? Okay, and lastly, a nurse asks you to check an IV flow rate where a pump is not used. What should you do? So we're going to count the drops for 1 minute. Okay, so that's it in a nutshell. So remember, I want you to go do your review questions now on Chapter 32. I want you to watch your skills videos on Evolve for Chapter 32. I want you to watch the YouTube's videos that are on Blackboard for this chapter. And go to that NHA site also. And remember, you've got Kahoots to go along with this. And I will see you soon.